and keep you in suspense about the vaccination discussion, build up the anticipation for that. So Lorraine's got a time constraint, so we'll hand immediately over to Lorraine for the IPQR.
Apologies, Chair. I've got someone at 3:15 just for the committee's benefit, so apologies for swapping the agenda. So we have the Highland HSCP IPQR in front of you today. We have taken together the usual data that we look at for in the main adult social care across unmet needs, our care homes and care at home, to give a picture of where we are. I guess overall on the numbers basis that we don't see significant changes in this data from month to month, which Simon will maybe go into a wee bit further. But the unmet need numbers, as you'll see, for this particular quarter have risen. In terms of our community hospitals and our people who are in the wrong place or delayed discharges, we have seen that increase as well in terms of our overall position as a board and within in our community hospitals. And you'll see on slide 11, our overall delayed discharges have dipped ever so slightly, but are still at a significantly high level. For our performance for PT, that has been improving in terms of our longer waits, and we're sitting at 45.6%, which is just below the Scottish average now in our board IPQR. And our waits for community mental health teams, we've got ongoing waits, but they are stable, although not where we would want them to be. For our ADP performance, that's the Alcohol and Drug Partnership, you'll see that there's been a significant increase over the previous year in terms of performance there, and that's above the standard now at 96.1%, which is positive. And on the last slide is non-reportable specialties. So these are our community areas. We still have long waits in some particular areas, but we are going through quite a substantial data quality exercise at the moment to make sure that that is correct, and that for those who are long waiting, that they've not been seen through a different waiting list. So we are looking at that in a bit more detail at the moment. On a wider sense, we are reviewing the whole of the Highland HSCP IPQR. We are just about to publish or to submit our draft annual delivery plan to government and our medium-term plan, and we need to reflect some of the data in our IPQR. For the board, we've started to take in patient or population experience within that, and I think it's something we've trialled that this month only for cancer. It was an easy area for me because that's a previous area that I've worked in, so I knew what I was looking for to trial it. But I think that there's a really important part about getting quality aspects and outcomes aspects within the IPQR moving forward. And there's a number of areas strategically that we've discussed as programmes or projects that I think that the data that we get from that will be of interest to the HSCP. So we will undertake to do a review of that with Pam and her team and Claire for the quality aspect by the next partnership meeting, and take back a revised format that incorporates wider indicators than what you see today. But happy to answer any questions.
Thank you very much, Lorraine. Simon, is there anything you want to add to Lorraine's introduction before we throw open to questions?
No, actually, I just keep it going, and that way then I can answer questions rather than put a narrative into this, if that's okay.
Okay, so I'll just throw open for questions. Muriel.
Thank you, Lorraine, as ever. Lorraine, what is deemed to be a long waiter for her with regard to health and social care?
So if they're non-MMI wait, so that's not reportable, then it would be over 18 weeks. We are just reviewing the whole waiting times guidance at the moment. There's new waiting time guidance come out just, I don't know, time flies, Muriel, but maybe about 6-8 weeks ago now. And we are looking at the application of that throughout the system. There's an improvement plan to be in at Scottish Government for all specialties by April. So it's about application of the right policies and weights, and really engaging with the population on, you know, do they still need the appointment, etc. So that is part of the data quality exercise that we're looking at, but also how do we really apply that across our system. So more on that to come. We've been doing quite a lot of engagement on that at the moment.
Anne.
Thanks, Jerry. Just a couple of questions. I wondered if we could hear a little bit more about the work of the Short Life Working Group that's been bringing forward the proposals on care at home. Just what the proposals are. Will they be discussed soon at Joint Monitoring Committee, or what would be the next steps for implementing those? And just a one-off. I heard recently about a digital solution that was being used elsewhere in relation to enhancing delayed discharge processes, where Health and Social Care Partnership had been enabling virtual home visits for assessment of things like AIDS and adaptations whilst people were still in hospital, whether acute or community. And it seemed to have had quite a big impact on enabling things to happen more quickly. So I just wondered if we used anything like that, and if not, whether it would be worth exploring something. Thanks.
Who wants to pick up Anne's question in terms of digital?
So in terms of digital then, we have really good developments now around technology-enabled care, looking at working jointly with families and carers just around that conversation around care at home, and where we're perhaps withdrawing care and replacing it with some technology-enabled care rather than as well as. So we've looked at instances where we've reviewed care packages and been able to reduce some of the time. So that should help us going forward. We are very low users in Highland of telecare, for example. So we've been looking into that and thinking about how we can maximise telecare for people, and also looking and working in partnership with the Highland Council around technology-enabled housing support, so that we can enable people to go home faster from hospital rather than keeping them in hospital whilst they wait for adaptations and things. Catherine Sutton and I have been looking across the whole system. We've actually got a meeting later on this afternoon with other wider colleagues, just around where we can get some of our support into the community around discharge to assess, so that we can set up people better to be technology enabled or assessed at home. So we're working really hard in that space. So I'm not sure if Simon wants to add anything on to that, specifically around our approach to care at home then, and looking at the sort of overall approach that we're taking to improving care at home. We're creating a care at home collaborative. So we've been working with the sector and working with partners so that we can co-produce and understand some of the issues that would improve their experience or enable them to get out to people more quickly. And also where people have care at certain times of the day, sometimes that's prescribed, but it might not work for them. So being flexible around packages is really important. We've been looking at joint training as well to make sure that where we commission or where we in-house provide care at home, we're able to look at maximising our collaborative approaches then to joint training and not trying to do things in isolation, so that we can share things across our services and our providers a bit. We've been looking at shared spaces and district hubs, and we've been looking at improving our information quality, which is, you know, in terms of information, a lot of the services within the partnership are maybe not as data informed as some of the, you know, the clear sort of waiting times or imperatives of the Scottish Government around acute care and urgent care. So we've been improving our information quality around care at home, and with that, people's experience of care and the experience of carers as well, you know, to work in that space. And also we're continuing to promote our proposals around advanced block payments and allowing our providers to, you know, to work more with our multidisciplinary team to reduce the rigidity, however prescribed it is by the Care Inspectorate, but to allow them to work more flexibly with families, so that we can open up some of our care at home capacity, and reduce those waits for people who are you know, waiting in hospital, so that they can go home as quickly as possible and avoid all of the deconditioning and you know, all of the issues that we spoke about earlier on in the meeting. Simon, do you want to add anything there?
Okay, Chair, just a couple of quick points. With regard to the work with the sector, we've got really good engagement with the care at home providers, and been working with them as we've done for a number of years, to be honest, looking at ways that we can improve the delivery of care at home in the quite straitened market we're in. And by that I mean the real challenge for us with care at home at the moment is very much around recruitment, and very much around the danger of in-house provision recruiting from the sector, and what we're really particularly needing to deal with that. But there is a comprehensive report that if the committee was minded to seek a report of that type, we could provide, which would allow you to get into the real detail of it. With regard to the technology side of things, I think there's three aspects to this that I would actually no, there's four. Sorry, 4 aspects of this, and I would reference for you. The first is the work that we need to undertake in Highland, which I think we are behind on, with what some people call citizen tech. So that's the idea of using things like Alexa's, other brands are available, to enable folk to get that sense of security or contact as needed. And that's kind of, for me, that's much more about reassurance and deferring the onset of statutory services. The other bit of technology we're using is particularly around apps to aid us in planning discharge, and that's been pretty successful, though we do need to make sure that it's being taken up by all disciplines. The third area is around the kind of back office functions, and we've been meeting with the Scottish Government, and that's partly about looking at digitising some of our financial assessment information, and particularly looking towards how we then link that to income maximisation and unclaimed benefits, etc., and seeing what we can do there. And then the final bit was the telecare bit, and I think it's quite important for us to recognise that we haven't had the uptake that you might have expected us to have of telecare, which is a bit surprising in some ways, given that we were one of the early leaders in telecare. And so there's a question about how we're promoting telecare, but also there's a question about who we're promoting telecare to. So the big thing for me with telecare is, or the big issue is probably more that we're using digital and alerting solutions as well as, rather than instead of. And I think that's one of the big things that we need to be addressing. We can make care go further where we're able to use digital and remote systems as a way of spreading what care we've got further. And that's quite simply down to the fact that we can't recruit into these posts at the moment. So those are the main areas that we're dealing with the digital side of it.
Thank you, Simon. Anne, you okay with that? David?
Thanks, Simon. Just picking up 2 points there. One is just around the whole telecare and the risk of the digital, of the analog switch off, where we are with that. And the other one is cost to the individual a barrier to people accepting telecare?
Is it okay if I just dive in on those, Chair? Is that right? So it's two things. There are two risks around digitisation. I think for us, one is as you know, the impending switch off, and we're looking at what the impact of that is likely to be. And the other is the fact that we don't have absolute coverage, particularly in terms of stability of signal, etc., around the Highlands. So I think there is a real issue for us with regard to, I suppose I would argue, rurality and what some people call digital poverty within the Highlands, because we can't assuredly provide those services. And the key thing here for me is the combination of reassurance and assurance. There's no sense in having something with a button that you press if when you press the button when you really need it, nothing happens. And that's the big issue for us there. With regard to the cost of telecare, actually, no, we don't have a problem around our telecare costs, and very few people, a tiny proportion, choose to have a financial assessment. It basically costs £6.50 a week. I think I need to double check that. I don't want to mislead committee on that, but it's about that, and that is not a cost that most people find prohibitive when taking into account what they get for that money, if you like.
Thank you, Simon. David, you okay with that? Yep. Thank you. I'm not seeing any other hands up. Oh, I think we might be missing one. Kay, I can see Kay's got a hand up now. I thought I was missing one. Thank you, Kay.
I mean, we use the telecare system for my mum, and the problems that we had setting it up was that you need somebody, although me and my sister were fairly close to where mum lived, we weren't within the range, so we had to persuade one of the neighbours to be the person, and that's the issue. You have to have neighbours or somebody who is within a certain distance in order to go there. My mum, because she was getting forgetful, did ask just about every month what this money was that was going off her bank account. And the only time it actually went off, I rushed from work all the way to Everton to find her in the garden, quite happily digging away. But she'd set the button off by accident, and she was so ashamed at causing all this fuss. The button went in the back drawer and was never worn again. I don't think so. So you can't, but it was getting the people to be on the list of first responders was the issue for us.
Simon, did you want to come in that?
Yeah, it's just that's a very important point when it comes to being able to roll it out further, and particularly in the most rural areas, and particularly where you start to consider distance. So we are at the moment reviewing the requirements for responders, and whether or not in some circumstances we may be looking at a paid response type service, because that's not what this is based on at the moment. Now, that's a significant service change. If we do go down that route, it would mean that there was a pressure that isn't currently there. So we would have to look at the case that says what it is that saves happening. But just to assure the committee that the case point has been noted, and we are looking to see if there's something something better we can do that would improve the access to those who don't have the prerequisite number of responders.
Okay, thank you very much, Simon. I'll maybe just draw the IPQR discussion to a close. I've just been reminded there in terms of our general comments. Can we please remember to respect confidentiality when we're making any comments? And I think there's been a couple of things where we're potentially at risk of identifying individuals just because of the use of services. So I think if we just bear that in mind, and I know it's always easy to forget that there's a recording going on and someone else might see that. IPQR would be nice to note and accept limited assurance. Lorraine, just a quick question from me, and I be absolutely honest, I've not been back and checked them all, but I think previously we've had moderate assurance. I don't know I don't know if the moderate assurance was incorrect or the limited assurance, or we've changed something that has brought us up a step. And I say that, and I haven't been back and checked them all, so apologies for that.
And I think that the assurance was changed because of the position that we're in with financial and our way forward in terms of the resources and projections that we've got in terms of the overall position. But happy to reflect on that. I think that we'll look at that as well for the board, IPQR as well, given the position that we're in with the planned care and the impact on both, hence the alignment.
Okay, thank you very much for that, Lorraine. So we'll take it as presented to us today, but thank you very much for your taking that forward and having a little look. Can I just ask our committee members happy to note the report and accept limited assurance? Okay, thank you very much. Just a quick comment from me, Lorraine. It's not related to this one. We're going to come on to the work plan later on, and it is my intention to have development sessions at some point during the year. I think your comments said it as well. I think it's time for us to revisit the IPQR as it relates to what's coming to the committee, and it doesn't need to be every committee in terms of getting that a fuller suite of metrics, which might allow us to think that little bit wider. I don't know what the answer is yet, but I think it's probably just that time for us to reflect upon that as a committee. And I know you've said it yourself in your opening remarks, Lorraine.
Yeah, I think if we could just think about what are our longer term or medium term aspirations and how we will look at that transformation through this committee, and then what is within our current year gift or that we want to make a difference on, and where are our gaps. So I think that would be really positive to look at that, Jerry.
Yeah, thank you very much for that, Lorraine. We'll do that when we're putting together the development session schedule. Thank you very much, Lorraine. Now we're going to move on to the vaccination transformation plan update. Now Tim is going to introduce us to this item. He has got a wider role across the health board for vaccination, as you might expect, and then Pam will come in and pick up the more detailed delivery aspects to that. And I won't say anything else. Just in case I cut across anything that Tim or Pam are about to say and get it hopelessly wrong. Thank you very much, Tim.
Thanks, Jerry. Just a quick general introduction. Vaccination's clearly a vital service and has been highlighted particularly with the development and implementation of COVID vaccination. The arrangements and the governance for vaccination are that the oversight for vaccination lies with the board, and under the vaccination transformation programme, delivery has moved from the board from GP delivery and the oversight through GP systems to board delivery and the oversight from the board. But the delivery of the vaccination service is the responsibility of health and social care partnerships. And so this paper, in the spirit of the way that the committee works, is principally around the work of the health and social care partnership and vaccination through that. There are a few things to highlight before I hand over to Pam, just in terms of developments. The transition within Highland HSCP from GP delivery to board delivery has not been without its difficulties, for a lot of reasons, whether it be the geographical isolation, remote and rural areas, the move to delivery within the delivery through the board during COVID, while most health boards had moved their delivery to board oversight before COVID. There are also issues with staffing and clinical governance. Overall, their performance has been reasonable. You'll see within the paper there's COVID vaccination, pneumococcal vaccination, and shingles set out, where our performance is reasonably in line with the rest of Scotland. Despite that, the issues with the quality of service and accessibility have led to difficulties and people unhappy with the service that they have received, which has led to Scottish Government escalating Highland HSCP for vaccination to level 2 in their escalation framework, which is not around anything specific on performance, but it's around the overall quality of the service and confidence in the delivery of the service. So Pam and I are meeting regularly with Scottish Government to address that. There is also help that we are getting from Public Health Scotland as a critical friend, and that's particularly important in another issue relating to overall vaccination, and that's childhood vaccination. Now, in the longer term, childhood vaccination, I think one could say, is more important than adult vaccination. Perhaps not more important than COVID, but certainly a very important area of vaccination. We've seen with recent measles, particularly in England, about the risks of low levels of vaccination. And just looking as an example on page 95 of the papers, while the scale starts at 75 and not 0, which is important to put a warning in, that MMR uptake and some other vaccination uptake is shown to be quite lower across NHS Highland as a whole, and the uptake within Highland HSCP is lower than that within, generally speaking, within the overall board figures. Things get better as children get older, but even then it demonstrates there's probably a bit of a delay in the vaccination. So we have, in summary, a system where there's limited confidence in the vaccination service from the general public. We faced problems and been able to get reasonable adult uptake, but there remain a lot of issues around the delivery of the service, and remaining particularly some concerns around childhood vaccination. So with that background, I'll hand over to Pam.
Thanks, Tim. So really important that engagement with stakeholders and the public, around their experience of receiving vaccines, or engaging with appointments and processes, etc., but also our stakeholders in terms of concerns from GPs, for example, about childhood immunisations, and concerns from the public as well, just around how we're performing in Highland. We are trying to be open and transparent around that. So with the Scottish Government being really helpful in terms of that level 2 escalation, asking us about people's experience, asking us about the distance travelled in terms of how we deliver vaccines remote and rurally to our population. So we do need to improve access in terms of the graphs and charts that you're looking at. Some by small margins, some by more significant margins. So that communication and engagement with the public and that whole public health messaging is really, really important. But also in terms of our frontline workforce, you know, the uptake of vaccinations, and also the staff experience in the service around delivering the vaccinations. We have been really challenged in the last year around you know, sustaining a vaccination service remote and rurally, for example. You know, we've used a lot of agency staff. There have been a number of you know, quality and patient safety issues that we've picked up through our quality and patient safety and people safety processes within the partnership. You know, so we've picked them up and reviewed datexes, etc., and made recommendations for learning, etc. So we're quite confident that people don't have to travel far for vaccinations. If we look at the chart on that, then we're reasonably confident that most people can receive their vaccination in less than a 20-mile radius, and a good percentage of people less than 1 mile or 5 miles, which is really good. And you know, people who travel just because of their choice, you know, we've made drop-in clinics at every clinic that's scheduled, so that where they're advertised, people know that they can drop in and get a vaccination. And some correlation with, you know, people may want to travel to large centres. For example, if you're coming to Inverness for shopping, you might want to drop in to the centre and get your vaccination there, rather than do something more remote and rurally associated with where you live. Nevertheless, if we look at our locality breakdowns, quite variable performance, we are looking at you know, providing our vaccination service in the future, aligning that into the districts, and we're currently you know, doing some stakeholder engagement, some professional engagement, looking at you know, making sure that we've got all of our partners engaged, including general practice, including the public, around what it might look like in terms of an option appraisal to deliver across the districts. Now, if we're going to align and deliver across the districts, we're maybe looking at a mixed model in terms of those options, and we are just currently drawing them up to make sure that we can improve our access to vaccinations for people, our delivery for infant vaccinations, which is really important, and also making sure that we can staff within the districts as well, because we've looked at the delivery, the cancellation rate of clinics where we've not, you know, where we've had workforce difficulties, and all sorts of things. And then there's opportunities within the districts as well in terms of places where we can deliver the vaccines. I know when I've been out, you know, across Highland, some of the local halls and you know, local bases where people may be delivering vaccines, the staff experience of that is a bit counterintuitive to a clinical environment, so that affects, you know, staff's experience in terms of working in that space. We have received a number of complaints from the public last year, largely related to the autumn and winter programme, difficulties with the national booking system, you know, doubling of clinics, people not seeing clinics availability because they seem to disappear off the portal, some families having inconsistent communication, so one person in a family having to travel 20 miles, the next person getting the next family member getting a letter a week later for something either more locally or sometimes further away. So we had a lot of issues to sort out with national booking and national portal. But locally within our own communications, we've been really you know, driving that message that where the clinics are advertised, you know, where people don't have an appointment, they can drop in and get one. So that's been working really well for the public. And our stage 1 complaints had a variety of issues and themes, but so far during 2024 then, fingers crossed, there's only been 1 or 2 complaints, both relating to shingles vaccination letters. So that's about people's experience, not actually a complaint about the service itself or the experience of attending a vaccination clinic. So that's really important. I think it's important to stress that, you know, in terms of looking to redesign the service and having the level 2 escalation to Scottish Government, and also that critical friend, Public Health Scotland did visit the board on the 27th of February and met with the vaccination teams and presented a lot of data to us in terms of how we understand our services is performing and where we might look to develop and deliver it further in the future. So we're not working in isolation. We're being very open about the challenges that there have been, either remote and rurally, or with the experience of vaccinations, or with the staff experience, or with the absolute delivery and performance in that area. So we're providing most vaccination programmes, as Tim has described, in line with national average uptake rates. We do know where to look at where we have to make sustained improvement. One area as well where things are needing to be more stabilised is around the staffing model. So if we're going to align the vaccination service and an option appraisal to the districts, we need to be very clear that we're going to be able to staff that, and there may be opportunities to have more alignment with multidisciplinary teams, but we may as well have to look at variation orders in terms of who and where we actually are able to sustain vaccination delivery. And we have to look through that lens and make sure that we engage with our stakeholders so that we get the right models going forward in terms of our vaccination delivery. Attached to the papers are the vaccination transformation programme, our key performance indicators. So they're written up for you there. Just the overall vaccination transformation programme and the community engagement, I think that's really important, not only about improving people's experience of vaccinations to get the uptake, but also just to keep people in that space about the public health messaging and the importance of vaccinations. So I'll stop there, and I'm happy to take questions. We do have a meeting on Tuesday just around being really clear about who our stakeholders are in terms of engaging about the options for the alignment into the districts. So as I said at the beginning, we're hoping to have that ready and in place and redesigned before the start of the 2024 autumn and winter programme. So something will come back to this committee either in terms of a development session to update or a paper to give assurance that we're moving in the right direction and that we've done the options and what they look like and how that would improve our delivery and uptake rates going forward. So the paper and the graphs and the charts and the data and the engagement and the monitoring, that's all offered in this paper, and we're offering moderate assurance despite the challenges. I think the moderate assurance is offered in terms of how we've looked at this, the processes that we've got in place, the plans and the engagement that we are taking forward. So I'll stop there. Thank you.
Thank you very much, Tim and Pam. I'll throw it open to questions in a second. So the delivery model as of today, and this is maybe for Pam and Tim, we have transitioned away from a GP delivered model, mainly, probably not exclusively, but mainly, and we're now into I might call it a centrally delivered.
Yes.
Where staff travel to designated locations to provide scheduled vaccine clinics.
Yes.
So I suppose my question may well be then, Pam, what would be different under a truly district delivered service, or what could be different? I appreciate you still got an option appraisal to go through. What could be different? What might look differently then?
So I'll explain some of what it might look like operationally, and I might invite Claire to come in and just describe a bit more about what that might look like in terms of delivery. if that's the case. But operationally, rather than moving people, so rather than moving staff, maybe a whole day's travel to maybe vaccinate 3 individuals, staff would be co-located in the district, and there might be access to like a wider multidisciplinary team, so that we can train up more people to do vaccines and think about the capacity locally. Rather than moving people, we would want to move consumables, so we would want to make sure that we've got storage out in the local districts, and that we're not travelling all the time with vaccines, and also handling multiple vaccines in areas. So, for example, you know, having a vaccination clinic in the local British Legion, for example, just as an example of an area of a premises that we might use for vaccinations. It's not a clinical area, it's a public area. So sometimes the staff, you know, don't have a good experience around that kind of clinical setting where they're used to delivering their vaccinations. And perhaps we can promote more co-located you know, interventions when people do turn up for vaccinations, when we've got a wider team, you know, so there may be an opportunity for other health promotion and health advice at a same clinic, rather than just singly for vaccination. So looking at it from a multidisciplinary point of view may give us more benefits as well. And that's all for option appraisal, and it's about improving the staff experience and improving the population's experience of vaccines. And there's also the quality and safety elements in here. And, you know, I've already invited Claire to come in, and I see that Louise has got her hand up as well. Thanks.
Claire, did you want to come in?
Quite happy for Louise to come in first, and then my comments will be aligned, I guess.
Thanks. And I suppose there's a couple of things just to reference. Not all staff live in Inverness and travel to points. So there are some staff that do live locally. So there's some staff that live on Skye, there's some staff that live in Caithness, etc. What we do have is somewhat more locally, centrally run system, so that we don't necessarily manage it in the districts. However, for some services like children's vaccines, there is much more of a travel across. And I think we need to get to a point where vaccinators vaccinate anybody, because we do tend to, at the moment, have that children and adult split for various reasons. So I think there is something about how we agree what that local versus board-wide model is, and where the synergies are between that. I think it's really key that when we're doing that options appraisal, the clinicians are there from the beginning of that conversation, because this is where we, you know, ultimately we need to get to something that people feel happy, comfortable and confident in, and that we can staff. So I think it's going to be key getting that options appraisal right.
Thank you, Louise. Anne.
Thanks, Jerry. So first of all, I think I'd like to acknowledge and you know, just say how welcome the transparent approach that we are taking is, in terms of, you know, identifying where we need to improve the service, and you know, going about that systematically. I suppose I do have a bit of a concern that we are, you know, coming up for mid-March. It will be May before you know, we have an options paper, and I guess that's if the consultation goes smoothly, and you know, we can get people on board with whatever option we want to promote. And then, you know, September won't be far away. So I guess what I'm wondering, Pam, is what your level of confidence is that we will be ready to implement, because it would be far better, you know, if there's any risk to that, I think, to acknowledge that now, and look at what the implication of that is. It may be that we can draw in more capacity to support your colleagues and in redesigning this service. I don't know if we have talked about how we can use some of the staff that have been working on the capital projects that are paused at the moment, for instance. I don't know if that's an option, but it's just a slight concern I have, given all of the other redesign work streams that will have to be progressed at the same time. So I just wonder what your thoughts are on that. Thanks.
So there,
can I just before you come in there, Claire's hand disappeared, but I think she wanted to come in just on the back of Louise's comment to maybe give you a little bit more time to think about the answer to Anne's question, Pam.
Thanks, Chair. I don't know what happened to my hand there. I had a mind of its own, or maybe someone put it down. Who knows? Anyway, and thanks, Anne. Yeah, I was just going to come in because I think Pam had asked in terms of from that professional perspective and also as a kind of QPS lead for the partnership. So there's two sort of slightly separate points. The QPS had identified some issues coming through in terms of our DATEX reporting, and so we've commissioned a paper which will be coming to Clinical Governance Board Committee to provide some assurance about how they're being worked through from that kind of operational delivery perspective. The second point, and perhaps as important from the professional leadership perspective, and I'm sure Neil will probably come in with a comment about this from the GP perspective, is looking for that assurance around about from an options appraisal, which has been something that from general practices would be and will be very welcomed, I think, to try and really understand what is the best delivery model to meet the needs of our patients, whether, you know, from a remote and rural perspective or in the urban. I wouldn't want to prejudge that, but I guess it was just in reference to the fact that that would be welcomed, but we need the professionals around about that with our data from what went before, understanding what's working well just now, what isn't, and then taking that forward, I think will be absolutely critical. So I just wanted to put in those 2 points, and I appreciate you letting me come in on that. Thanks, Jerry. Chair, even.
No, thank you, Claire. Pam, back to your good self.
No, I think that's helpful for Claire stepping in there, because in terms of capacity and the kind of nuts and bolts of you know, developing the option appraisals and using the skill set that we've had around some of our capital redesigns that have been paused, then you know that's really good to have that support. But this does need to be clinically led and appraised both within the organisation and with our stakeholders as well across general practice and you know, public health. So getting the stakeholders right is going to be important. In terms of sequencing, as Louise already mentioned, you know, some staff do live locally. They're not all centralised in Inverness, so we may be able to incrementally, you know, put proposals to incrementally move into the district alignment in some areas where we may have confidence that already works well, and we may be able to use that to help develop and drive quality improvement as we move to that model, so that we're not just saying from a certain date we're going to do X, and that might be problematic, because we've still got to work with the National Booking Service. You know, that there's still some of the national policy and national systems that could derail us, that we've got to keep ahead of the curve. And that's when, you know, the administrators within the system and you know, the clinicians within the system are working with that every day. So I think there's areas where we can adopt early, where we're aligned early, where it currently feels comfortable and successful, and we've got good engagement, and you know, take it from there. But you know, clinical engagement and stakeholder engagement is going to be absolutely, you know, essential in this, as well as the views of our critical friends, you know, in the government. You know, as we go through our level 2 performance, we're looking at, you know, meeting with the government very, very regularly. So using them as that critical friend with that lens as well, so that we are working in the right policy space, is going to be important too. Thank you.
Thank you, Pam. Muriel.
Thank you. I just want to endorse what Anne said. I was going to highlight a couple of the things as well. One thing that I would say there is a perception out there, and I think we need to get communication. We talk about communication a lot, is that it's much worse than it was during COVID times. Now we know that the models have all changed and you've got a different range of vaccinations. However, I think it's important that we really look at getting some sort of solution before the next vaccination key cohort, and it's unbelievable that it's March already. One thing I would say, I have had numerous emails from people remote, rural, and in some of our big urban towns in my area, and I've referred them to the email service. And that has been I've had really good feedback from that. So I think that's, that goes well. So instead of, this is not a criticism of the whole team, but there are aspects that work. But I wondered if there was any, looking at any of the models that are being rolled out in other areas of Highland services. For example, the breast screening services are having capacity issues, and they're sending letters out to patients saying that there will be a delay if you wait for the service coming to your locality. However, we have got capacity in Inverness. I wonder if that is possibly a consideration, and key is working with the GP practices as well, because I'm sure their teams must be so frustrated with the number of vaccination calls they get.
Absolutely, and we do offer choice to patients in a number of areas of healthcare delivery, and offering that choice, even though we're devolving into the districts, we may want to still offer choice to people to travel. If they live over in Skye, they may want to come into Inverness and have their vaccination if they're shopping, and if they're going for other appointments, for example, if they're going to Raigmore for an outpatient appointment, that they can still link in the drop-in aspect of the clinic. So it's within our gift to set things up to be flexible and focused to the population, just around choice and convenience, so that we can actually engage and improve their uptake, rather than people feeling that there's barriers to accessing services, and we make the best use of their travel commitments as well. Okay.
Thank you, Pam. Thank you, Pam. Neil.
Hi, thanks, Chair. Yeah, just to reinforce the ideas that options appraisals around the patch are going to be a very good idea. It's kind of gratifying to see that government has now come round to that point of view, that actually we are going to need to do that. I was glancing at some of the figures, and I was looking at flu vaccinations, 50% for my patch Lochaber. I can't give you chapter and verse, but I'm pretty sure we scored rather significantly higher than that, 22, 23. But as I say, I can't give you chapter and verse. I think, as has been said before, comparing previous years with current achievements will be very important. People's experiences are obviously vital, but at the end of the day, you need needles in arms, and you need people vaccinated in order to get the overall public health benefit. So the figures hopefully won't lie, and we'll be able to see what's happening there. I do think involvement of clinicians, and by that I mean my colleagues and local clinicians who know their communities, is going to be vital. I would ask Pam, is there going to be GP representation at your Tuesday meeting?
So Tuesday is a meeting to make sure that we've got the proper stakeholder engagement. So that's identifying the people that we need to engage with, but definitely we want to and need to engage with general practice. And also, as part of the options appraisal, we will be considering variation orders where the data and the experience and the remote and ruralness directs us in that way. So definitely, you know, general practice GPs are absolutely key stakeholders. And, you know, I know that a number of concerns have been raised around the infant vaccines from across your colleagues. So it's really important that we hear their voice and we respond to that.
Okay, thank you very much for that, Pam and Tim. I think what we've clearly got here is a fairly complex solution which we're going to try and put in place. And I have to be honest, I share the concerns that Anne has set out. So I think it might be useful, Pam, for the next meeting if we get an update, probably within the Chief Officer's report, of your proposed timeline and process. We don't need any detail, but I think a process and a timeline would be useful in there. So in terms of the actual report we've got in front of us, we're asked to note the report and accept moderate assurance. Are we content to do so? Okay, thank you very much indeed. And I'm very conscious of time, so we are really going to get our skates on, folks. We are really going to get our skates on. But Chief Officer's report, Pam.
Thank you. So just very quickly, I'm conscious of time. You know, I've given an update around the major redesign programmes. You know, in terms of the capital funding announcement from the Scottish Government and how we've paused on the capital programmes. Nevertheless, you know, we are progressing, you know, service redesign work. So I've put something in about our Longberry Care, which has been a joint development with the Highland Council. So you know, within the redesign of the North Coast, then we are still making progress and making sure that we develop and deliver options for people. Also, in terms of the Lochaber community redesign, you know, we're continuing to work at that at pace, and we're actually just articulating and agreeing a model at the moment where we're going to join up and make sure that we are still progressing the community aspects of Caithness and Lochaber, so that we maximise the benefits and we are consistent around models of care and particularly workforce planning, and that we get into that space, and that we keep our eye on you know, the work that we need to do in terms of articulating our capital planning going forward. So still having some of the people from the programme designs and capital designs around the table, so that we can still take that forward, you know, and engaging with the government as necessary. So that seems to be in a good space, and we've got really good engagement locally, both in Caithness and in Lochaber for the hospital and the community redesigns, and you know, we're working together in that space. I've put in about the joint inspection, adult support and protection inspection for Highland. So I just wanted to put in a bit of detail about that in my Chief Officer's report. There's quite a lot of active work going on. We've had a visit from the Care Inspectorate, who are leading on the inspection on behalf of the agencies. And you know, they were really pleased when they attended the meeting with the board with the organisation at Ascent House. They were very pleased to have an acute chief officer there. They said that, you know, that wasn't really explicit in a lot of other organisations that they'd been into. So we were really able to put across that emphasis of, you know, adult support and protection is for everyone. You know, it's for clinical people as well as social work, as well as the police, you know, our agency partners, housing colleagues, council colleagues, for example. So we're well on with the activities that we need to do in terms of what we've got to provide for the Care Inspectorate. We've been working together with our public protection partners. The staff survey's been out. We've got regular adult support and protection, multi-agency inspection planning meetings in the diary. So we feel well prepared. We've had a development session with the board, you know, and across our services, we've been engaging and preparing staff who may be asked, and obviously we've got a number of evidence to provide. So just an update so that people are aware of what we're doing in that space. And also at last committee meeting, Neil had brought up the experience and the issue around the enhanced services contract. So we've been working very hard with our general practice colleagues. We've been developing revisiting our terms of communication, if you like, and engagement, and being very clear about what we mean by negotiation and who's round that table, so that all of our general practice partners are represented in the correct way, and that we're open and transparent with our communications. And we are still in negotiations about what the enhanced services will look like from the 1st of April. And that's coming into communication in due course. I think that's all that's in my Chief Officer's report. Thank you,
Pam. Any questions for Pam on any of those topics? Philip?
Sorry, conscious of time as well, but just going back to the redesign, particularly Caithness area, and I'm aware that you said that you're content with the local engagement what we've got, but I certainly know that we've been having problems with the Caithness hubs and the issues surrounding those, which are separate. I just wonder if we're content that we don't need to do any wider engagement with the particularly the Caithness public, and I just wonder if we need to reconsider any messages that are going out. We need to widen them, increase them. I'm just conscious that there is a kind of a bubble of perhaps dissatisfaction that we maybe need to do a wee bit more.
Yeah, keeping the public and our communities and our citizens informed and engaged, and all of our stakeholders is really important. So working hard in that space, being visible. I think there's a number of us going out to local areas to be visible. I'm going over to Granton tomorrow evening because there's been issues around the developments there with the GP practice and the Ian Charles Hospital. So Muriel's coming along to that as well. So I think we're trying to be visible, and we're trying to connect with communities, community councils, and with all of our professional colleagues as well in that space who are delivering services locally. As things kind of shape and change. So a good point, Philip, and I would want to offer assurance that if requests are made for us to come and engage with any fora, then we're more than happy to come up and do that.
Thank you very much. Thank you very much, Pam. Okay, we've just been asked to consider the report and identify any matters that require further assurance and escalation to NHS Highland Board, and I'm assuming that there is nothing there which we need to move on. People happy with that? Okay, we'll move very quickly on to section 4, and I'll almost take these three as one. We've got three reports there really, which are really there for the committee to note. We've got our draft work plan for 24-25, which really is a live document, and we'll be amending that as we move throughout the year, and that's really there just for members to note. We've got a draft annual report there, and I'm asking for committee. That was drafted by Pam and myself predominantly, with input from Stephen. I'm just asking people to endorse that annual report. We're not proposing to identify any issues to the NHS board, but I'll give people the opportunity just to email me directly if they've got any issues that they would just like to bring out in that report. And that report will go to the audit committee, I think, at the beginning of May, and then onward to the NHS board as part of the whole assurance process for the annual accounts. And finally, we've got the self-assessment exercise I've added into the paper, which was circulated for our get together in February, the end of January, in terms of the thoughts of people who attended on the day. Again, I'll just take if anybody's got anything which they would like me to amend on that, I'm happy to do so. I've submitted that to Sarah, the chair of the board, and I've already begun discussions in terms of how we might move that forward, and I think it's something we'll try and revisit as we move across the year, and we'll build it into the work plan in terms of development session. So if everybody's happy, I would hopefully we will note and endorse those reports as proposed on the agenda. Okay, thank you very much. Any other competent business? Nope, I'm not seeing any other hands up, so we will bring the meeting to a close. And if we note on there, date and time of next meeting, the 8th of May 2023, and it seems ridiculous that we're already talking about meetings in May. But how time flies when you're having fun. Thank you very much indeed, everyone. A small overrun there, but we got there in the end. Thank you. Bye-bye.
Bye.